Hello, and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson, and Associate Professor of Pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. If you happen to be looking at the thumbnail of the podcast, Dr. Price is the dashing young man on the right, and I'm the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks for tuning in today. This is the week of January 13th, 2025. I hope everyone had a great end to 2024. Let's just go ahead and jump into the questions. Question number one from a listener asks, can you review the 2025 immunization schedule updates for children and adolescents? Sure. Let's go ahead and look at the updates from this last year. Now, when we're looking specifically at the pediatric population, there aren't a lot of huge updates to the vaccine schedule. And because I'm a pediatrician, I'm going to willfully ignore any of the adult updates. So apologies if I'm going to keep this limited to just children. First up, the updated CDC recommendations for COVID-19 recommend that all individuals over 6 months old should receive one dose of the updated 2024-2025 COVID-19 vaccine. Now, this is an update from the 2023-24 formulation that was put out a year ago. And the most important update on this vaccine is that it's now targeting a different viral strain than was in the previous 2023 preparation. I'm going to get into this a little bit more in depth in a future question, so I'm just going to leave that there for now. Additionally, for individuals over 6 months old who are immunocompromised, the recommendation is that those individuals should receive 2 doses of the updated 2024-25 vaccine, with the second dose being given 6 months after the initial dose. There was additionally an update to the recommendations for immunization against Haemophilus influenza B. So I think a lot of pediatricians know that Native American and Alaskan Native children are at an increased risk for invasive disease with Hib. Interestingly, it's a pretty significant increase with 31-fold higher incidence of invasive disease compared to non-native children, according to CDC data. Because of this, the recommendations have always said that for Native American or Alaskan Native patients, they should be receiving the PEDVAX Hib immunization. Now, that's because this immunization is linked to a carrier protein called PRP-OMP. For those of you that don't follow immunization science very closely, this is an outer membrane protein from the meningococcus bacteria. Now, the good thing about this is that it generates a pretty robust inflammatory or immune response, and so as a result, it provides improved immunity after even the first dose in the infant series. As a result, this is the vaccine that has been recommended to make sure that those patients who are at really high risk for Hib disease are protected immediately at that 2-month immunization series. So while PEDVAX Hib has been the recommendation for the last several years for these patients, there is a newer vaccine product called Vaxelis, which was licensed in 2018, which was developed by a company called MSP Vaccine Company, a joint venture between Merck and Sanofi. Now, this vaccine also has PRP-OMP in the vaccine preparation, but in slightly lower doses. This vaccine is a combination immunization, so it also contains immunization against diphtheria, tetanus, pertussis, polio, and hepatitis B. So definitely a product that is useful in infants receiving their infant series. Now, recent immunogenicity data shows that there is similar immunogenicity after the first dose of Vaxelis compared to PEDVAX Hib. And so this last year, the updated recommendation against Haemophilus influenza B is that either product can be used in Native American or Alaskan Native pediatric patients with no preference between the products. With regard to influenza for the 2024-2025 season, I think it's important to point out that the products available this year are all trivalent preparations as opposed to the quadrivalent vaccines that I think we had all become accustomed to over the last decade. Now, the reason for the transition to trivalent vaccines is because during the COVID pandemic, interestingly, we saw the disappearance of the Yamagata lineage of influenza B. Now, this is because influenza B only infects humans and doesn't have an animal reservoir. So with the mitigation efforts like masking, social distancing, and closing down schools, we saw Yamagata completely disappear from the human population over the last several years, and therefore the recommendation is that we no longer vaccinate against this lineage. Additionally, for influenza, with the most recent updated CDC guidelines, there is an allowance that individuals who are 18 years or older who have undergone solid organ transplant and are currently on immunosuppression, that like older adults over the last several years, those younger immunosuppressed patients can be candidates for either high-dose inactivated or adjuvanted flu vaccine. Now, my guess is that a lot of pediatric providers aren't as comfortable with or practiced in those specific products, but just to be aware, both of those were developed to generate a more robust immune response in older adults that may not have as much of an immune response to standard dose of the flu immunization. Now, there is no preference for either high dose, adjuvanted, or standard dose in those patient populations, but it is an allowance now for our teenage population solid organ transplant patients. Those of us who follow immunizations closely were hoping or anticipating that we'd see some guidance on meningitis B vaccines, and specifically the question whether or not they were going to be recommended as standard, similar to the quadrivalent meningitis vaccine, or if they were going to continue to be recommended as under shared decision-making as they have been the last few years. Now, this data is still being evaluated by the ACIP, so we don't have any updated recommendations for the time being. However, they did recommend that the Bexsero or MenB4C product from GlaxoSmithKline can be changed to a 2-dose series in healthy individuals who are not at risk. And the reason for this change was to simplify the recommendations and harmonize them with the Trumenba. If you'll remember, that's the other meningitis B vaccine available. So for low-risk, healthy adolescents, the current recommendation is that you can immunize with either Bexsero or Trumenba, and both of them should be administered as a 2-dose series at 0 and 6 months. And for individuals who are considered at high risk for meningitis B disease, such as asplenic patients or those who are immunocompromised, the recommendation is that those individuals should receive a 3-dose series at 0, 1 to 2, and then at 6 months. And then the last big update, or I guess it's more of a clarification to the vaccine schedule in this last year, was with regard to RSV. So there was a little bit of confusion based on the previous guidance as to how infants who are born during current RSV season should be managed. And so the guidelines this year clarify and state that infants who are born between October and March should ideally receive their first monoclonal antibody, nirsevimab, or Beyfortus, before their discharge from birth hospitalization to make sure that they're well protected before they are out in the community and potentially exposed before they could receive the first dose at their pediatrician's office. And finally, with RSV, because there was some confusion about whether or not infants from subsequent pregnancies are still protected if mothers receive RSV vaccination with a previous pregnancy, the guidelines have been updated to state that if mothers did receive RSV vaccine in their previous pregnancy, but not the current, then those infants should also be candidates for nirsevimab receipt. So those are the updates to the vaccine schedule from the last year. And while this is a little bit off topic, I do think there's some important things to bring up from one of the most recent ACIP meetings in October of 2024, mainly just because I think it's worth being aware of these updates that may be coming in the next year. For example, the ACIP reviewed data regarding FluMist. So in September of 2024, FluMist was actually FDA approved for either self or caregiver administration. Now, the ACIP is still reviewing this data, so they haven't made any recommendations for the time being. However, there is some expectation that flu mist in the 2025-26 influenza season is going to be potentially available either by self or caregiver administration, so something to be aware of going into the next year. Additionally, the ACIP in the fall looked at data on a new long-acting monoclonal RSV antibody called clesrovimab, which is manufactured by Merck. Now, the final determination hasn't been made on this product. However, there is going to be further analysis performed at the February 2025 ACIP meeting, so we may see some updates on that. Now, clesrovimab is not yet FDA approved. However, it looks like they are potentially going to be making a decision in 2025. So again, something that we may hear more about over the next year. And that's about it for all of the updates to the vaccine schedule. Let's move on to question 2. So another provider asks, the Arizona Department of Health Services is reporting the first human bird flu cases in Arizona. What should pediatricians know about the bird flu? Before I jump into the question, I'm just going to clear up a few terms here, just so that I'm clear going forward. So the medical term for bird flu is highly pathogenic avian influenza, or HPAI. Now, I think it's important to kind of lay that out in advance, because even though in the news currently we've been hearing a lot about H5N1, I think it's important to remember that that's only one of the viruses of concern that can cause avian influenza. So avian influenza can be caused by a variety of different influenza A strain types, and much like other types of flu A, it's characterized by its hemagglutinin component. So as I mentioned before, the most recent avian influenza varieties that we've been concerned about are the H5N1 that's currently circulating, as well as H7N9, H5N6, and H9N2. The avian influenza circulating right now that there's been a lot of focus on, as I mentioned previously, is H5N1, and this virus was initially detected in the U.S. in 1996. Now, it primarily is active in wild bird populations, and transmission to humans has been historically rare. And when it does occur, it usually causes infection in adults who have heavy exposure to birds, whether in poultry farms, bird markets, or every summer you'll hear of a few concerning cases from state or county fairs. Like I said before, transmission to humans is relatively rare, but transmission to other mammal species is more common, including cows and pigs, in whom there is a lot of concern for possible reassortment events, which could lead to the emergence of new flu variants that infect humans more easily. In March of 2024 is when the initial cases in the current H5N1 outbreak were identified, and initially it was identified in the U.S. dairy cow population. As of January 2025, 915 dairy herds across 16 different states in the U.S. have been affected, and there have also been outbreaks in poultry identified in all 50 states. Additionally, there have been identified cases of spread to other animals, including pigs and cats. And since the beginning of 2024, there have been 60 cases in humans in 7 different states in the U.S. identified. As of now, there haven't been any confirmed human cases in Arizona, with 2 probable cases from occupational exposure at poultry farms, but we do know that it has been identified in wild bird populations in Arizona, so it is important to know about the disease, particularly for consistent symptoms in patients with significant exposures. Again, most of those exposures in the U.S. have been due to occupational exposure to farm animals or birds. Now, while I mentioned previously there has been a high case fatality rate associated with avian influenza among humans, thankfully since 2024, the symptoms that have been identified in infected individuals have been relatively mild, with conjunctivitis being a common finding, and some workers in Washington state having mild URI symptoms. Now, there have been some cases in the lay media recently that raise concern. So, for example, I think some of us have heard of a teenager in Canada who was hospitalized with severe respiratory distress and no known epidemiologic link to either prior cases or farm animals. Now, a few things to point out about this case is that, at least based on data we do know, this is a young individual with asthma, so they were at risk for more severe respiratory disease to begin with. Additionally, molecular characterization of the virus shows that it is a different strain than the avian influenza that is circulating in the United States right now. Then additionally, just this last week, there was an individual in Louisiana who died with avian influenza infection. However, at least according to data provided by the CDC, it appears that this individual also was infected with the different genotype than is circulating among U.S. dairy cattle. This individual who passed away in Louisiana also apparently had exposure to backyard flocks and wild birds. So while it's encouraging that these two individuals who have experienced severe disease from avian influenza recently aren't infected with the same subtype that has been circulating among dairy cattle, the concern is that if the current circulating strain in cattle reassorts and ends up leading to easier infection or transmission between humans, that we could see pretty rapid spread of the virus within the population. Now, encouragingly, like I said previously, most of the cases of avian influenza that appear to be associated with the outbreak among farm animals and birds don't seem to be as severe as historically has been reported. So even though mortality is reported as close to 50% with avian influenza, my best guess is that this is because the severe cases that have occurred in the past were actually evaluated for avian influenza. Whereas if we were testing more liberally anyone with respiratory symptoms or conjunctivitis or exposure to farm animals, we might see that the overall number of infected individuals is much higher, meaning that the mortality rate is hopefully a lot lower than 50%. And supporting this assumption is a recent CDC survey of dairy workers exposed to infected cows since 2024, which actually showed a 7% seroprevalence, with 50% of those individuals identified being asymptomatic. So again, probably a lot more individuals who are exposed and infected than ever develop either symptomatic disease or severe disease. Encouragingly, as of now, there have been no reports of human-to-human transmission of either the avian influenza genotype circulating among dairy cattle and wild birds, or the genotype that has been identified in the two previous individuals I mentioned who had severe respiratory disease. Also encouragingly, even though the virus is circulating among dairy cattle in the U.S., it appears that pasteurization actually does a good job of killing the virus so that it's not at risk for causing infection within humans who consume the milk. The milk supply is being monitored, and estimates are that about 1 in 5 samples tested had detectable H5N1 fragments, but again, there was no identified intact virus capable of causing infection in those samples tested. Now, we know that it can be transmitted in raw milk that's not pasteurized, and this actually led to a recall in California in 2024. So I think that's an important point to make to our families, is that though there seems to be an increased interest in raw milk over the last few years, which personally I don't quite understand, but it's important to let families know in light of avian influenza that we know it can be transmitted through raw milk. So families need to be careful about consumption of unpasteurized milk products. In addition to testing the milk supply, the departments of health across multiple different states have been doing wastewater monitoring for H5N1 at 190 different wastewater treatment facilities to try to identify any early increase in activity in various communities. Thus far, that data doesn't seem to support the concern that there may be subclinical transmission within communities that we're just not aware of yet. As I mentioned before, thankfully symptoms with this strain of avian influenza in humans tends to be mild currently, with mainly either mild URI symptoms or conjunctivitis. So if you happen to see a patient in clinic who has significant exposures to either farm or wild animals and is presenting with these symptoms, I think it's reasonable to ask yourself, could this be avian influenza? Now, if you are concerned, it'd be important to contact your local health department. Now, in part, that's because the commercial testing available for influenza may be adequate to pick up an influenza infection because, as I mentioned before, these are primarily influenza A variants. However, because the commercial influenza tests that are out there are looking for either H1 or H3, those tests may not be fully sensitive to identify H5N1. There are specific H5N1 tests that are available. Unfortunately, as of now, they're only available either through state health departments or the CDC. There are vaccines to prevent avian influenza infection. However, these have been licensed for several years and are only available through the Strategic National Stockpile, or SNS, which is controlled by the CDC. Because they were developed prior to the emergence of the current H5N1 strain, it's unclear how effective these vaccines are going to be at protecting against the currently circulating avian influenza strain. There are vaccines currently in development, including one mRNA lipid nanoparticle candidate that has promising immunogenicity studies so far in animals. But this vaccine and others is currently unavailable for use in human patients. So while the seasonal influenza vaccine that's available doesn't protect against avian influenza, immunization against routine seasonal influenza is still important because it can, in theory, prevent co-infection in humans. And as I've alluded to a few times previously when discussing this question, we know that co-infection with either an avian or animal influenza strain and then a human strain in the same subject could lead to viral reassortment that leads to the emergence of a new influenza variant that could transmit easily between humans, but because of its novelty, could also cause widespread and severe illness, which is the big concern for the emergence of a new pandemic strain. And in fact, the thought is that this is what occurred back in 1918 with the Spanish flu pandemic. So even though, as I said, the seasonal influenza vaccine is not going to prevent H5N1, it's still pretty important to be encouraging our kids and our families to be getting the influenza vaccine this upcoming season. Now, the good news to all of this is that antiviral medications that we use against routine influenza still seem to be effective against H5 variants. So medications including oseltamivir, peramivir, and zanamivir all seem to maintain activity against the H5N1 virus. Currently, the CDC considers the H5 virus low risk to the public health, but because of the concern for possible changes in the virus that lead to a pandemic emergence, obviously this is being watched very closely. If you really want to read up more on this, the CDC has a great website for updates that you can reference. So I hope all that information helps when you're thinking about avian influenza or H5N1. There obviously is a lot of interest in this right now, so if there are further questions or someone out there wants clarification, please feel free to email in after the show, and with the future episodes, we'll try to clarify or add more detail. All right, let's move on to question 3. So another listener wrote in asking, has there been any data released on the efficacy of fall 2024 COVID boosters in terms of preventing illness, hospitalization, or death compared to those who were previously vaccinated but not recently boosted? With a secondary question of any data on comparative effectiveness of recent COVID booster versus recent COVID infection. Well, I think the first thing to say here quickly is no. With the newer 2024-2025 COVID immunization that was just released, we really don't have the clinical follow-up data yet to give a really good estimate of the vaccine effectiveness compared to either natural immunity that occurs after an infection or prior immunizations. So even though we don't have that information yet, I do think that we can look back at data that's available from prior immunizations to draw some inferences about what to expect from the updated vaccine. And to do this, I'd like to look at a report from July 2024 that was presented initially to the ACIP when they were making a decision about recommendations for the updated vaccine. And then this data was published by the CDC in September of 2024. So basically what they provided was what's called a grade review. And GRADE stands for Grading of Recommendations, Assessment, Development, and Evaluation. And this is a specific type of review that's done by ACIP when they are making recommendations for immunizations to the CDC. In this study, they evaluated data from use of both the bivalent vaccine that was available earlier in the COVID pandemic or the 2023-2024 formulation. This data was drawn from 2 years of 2022 through 2024, and it included a review of 13 prior vaccine effectiveness studies to calculate the pooled effectiveness estimates of those prior vaccine products. Now, in this study, they found that vaccination was associated with a lower risk of medically attenuated COVID-19 with a vaccine effectiveness of 43%, hospitalization due to COVID-19 with a vaccine effectiveness of 44%, and death from COVID-19 with a vaccine effectiveness of 28% among all individuals. They then did a subset analysis to look at pediatric patients, and they found that in that population, there was a lower risk of medically attenuated COVID infection in infants and children with a vaccine effectiveness of 80%, which is pretty impressive. Now, because severe disease in infants and children is not as common as in adults, the study was not able to look at vaccine effectiveness to prevent either hospitalization or death from COVID-19. However, the authors did say that the data taken from the pooled analysis did provide indirect evidence for benefits of prevention of hospitalization and death in the pediatric population as well. And though this study didn't look at the outcomes of multisystem inflammatory syndrome, or MIS-C, or long COVID in children, we do know from prior studies that immunization is protective against both of these outcomes that we as pediatricians worry about. Now, as I mentioned, this study was looking at both the bivalent and the 2023-24 preparation of the vaccine. So not exactly reflective of what to expect from the newer 2024-25 vaccine. But I think what's important to point out is that since mid-2021, all of the emerging variants of COVID-19 that we have seen circulating are variants within the Omicron family of viruses. And the reason that's important to point out is that those viruses have been changing pretty quickly over the last 2 years, such that the circulating strains are oftentimes different than the vaccine strain that was used to develop the immunizations we've been relying on. Now, the good news is, ever since the main strains have been derivative from Omicron, vaccination seems to be maintaining its effectiveness, even if the virus has mutated away from the original vaccine strain. So, for example, back in 2023, the 2023-24 formulation of the immunization was based off of the XBB.1.5 virus. However, as 2023 progressed, that virus was quickly replaced by the JN1 and the KP2 viruses by the end of the year. Now, even though the virus itself has changed, it doesn't look like the vaccine effectiveness has been impacted. So the hope is that as we're going forward, as long as our vaccine platform is based off of the Omicron variant, if that is the majority virus that is circulating, even with small changes, hopefully the vaccine effectiveness is going to be maintained. Importantly, the CDC study that I cited previously also looked at adverse events following immunization. And they found that adverse events were quite rare following immunization, including myocarditis, which, based on the most recent data, the estimates are about 23.9 cases per million doses of bivalent vaccine administered, and anaphylaxis, which is even more rare, with an estimated 5.1 cases per million doses administered. So this is important because I think we have good data to say that the COVID vaccine that was recently released should have retained good vaccine effectiveness while at the same time having very low rates of adverse events. And this is important to know that the rates of adverse events are rare among immunized individuals because we wanted to compare the vaccine to the immunity that's provided by natural infection. So we know from prior studies performed earlier in the pandemic that natural immunity seems to provide equivalent protection against future infection compared to immunizations for about 3 to 4 months. Now, unfortunately, the immunity after immunization also wanes after about 3 to 4 months. Primarily, we think because immunization against COVID doesn't seem to lead to long-lived plasma cells, which are important for long-term immunity. So, at least based on current data, it does seem that the immunity provided by both infection and immunization are fairly equivalent. However, I think we need to remember that it's important to provide that immunity in a way that minimizes the risks of severe outcomes. And I think at this point in the pandemic, we can all agree that the risks of severe events with natural infection are much higher than the adverse events that can occur after immunization. So, in summary, I apologize I wasn't able to answer specifically the listener's question, but perhaps this is a question we can come back to later in 2025 once we know a little bit more about the vaccine effectiveness of this specific updated 2024-2025 COVID vaccine. All right, and that's it for questions for this week. Thank you again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you again next time on ID Talk.